So hello, good morning, good afternoon and good evening to all our speakers, chairs and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars and wish you all a very happy new year. The speaker for the first session of today is our honorable guest from Germany, Dr. Katharina Wolf. Dr. Wolf is a clinician scientist at the Department of Neurosurgery, University Hospital Freiburg, Germany. She is a part of the interdisciplinary team that includes clinicians, surgeons, radiologists and physicists collaborating to enhance the understanding of CSF homeostasis in both healthy and impaired conditions. Dr. Wolf's clinical focus is on spontaneous intracranial hypotension and idiopathic intracranial hypertension. Her primary research centers on CSF flow and CNS motion utilizing phase contrast MRI, and her team has made significant strides in understanding CSF and CNS dynamics in patients with conditions such as degenerative cervical myelopathy, spontaneous intracranial hypotension, idiopathic intracranial hypertension and NEPH. We are extremely honored to have her today at our webinars, and today she'll be talking about spontaneous intracranial hypertension dilemmas in diagnosis. The speaker for the second session of today is our honored guest from China, Dr. Ding Xinghua. Dr. Xinghua is a consultant neurosurgeon at the Huashan Hospital affiliated to the Fudan University Pediatric Neurosurgery subspecialty. He is mainly engaged in basic and clinical research on pediatric brain tumors. He has undergone advanced microneurosurgery training from South Korea, Germany and Helsinki. He has published several papers in various peer-reviewed journals and also has been rewarded by his government for his contributions to neurosurgery. We are extremely honored to have him today at our webinars, and today he will be talking about differential diagnosis of common tumors in posterior fossa based on diffusion weighted imaging. The chair for the first session of today is our honorable guest from Germany, Professor Jürgen Beck. Dr. Beck is a chair in the Department of Neurosurgery and speaker at Neurocenter, University of Freiburg, Germany. His clinical practice is focused on brain and interspinal tumors, vascular, skull-based, spontaneous intracranial hypotension, and epilepsy. His research interests are focused on neuro-oncological molecular imaging, quantum magnetic imaging, and translational research. He is the head of the CSF Center, Freiburg, as well as intracerebral hemorrhage and cerebral vasospasm. He is one of the founders of CAST and first SIH boards in Switzerland and Germany. He was a pivotal member in the AWMF guidelines writing for the ICP, SIH and brain abscess. He is a national ACNS delegate and a member of the ACNS vascular and the CSF section. We are extremely grateful to him for accepting an invitation to chair the first session of today's webinar. The chair for the second session of today's webinar is our honorable guest from India, Dr. Suhas Udaykumaran. Prof. Suhas is a professor in the Department of Pediatric Neurosurgery, Pediatric Craniofacial Surgery at the Amrita Institute of Medical Sciences, Amrita University, Cochin, India. He completed his subspecialization in neurosurgery from the King Edward Memorial Hospital, Mumbai, and thereafter subspecialization in pediatric neurosurgery at the Dana Children's Hospital, Tel Aviv University, Israel. He has more than 50 international publications in various journals and has number of international conference presentations. He is involved in multiple research projects in neurosurgery in association with the Amrita Center for Nanoscience and Molecular Medicine. We are extremely grateful and honored to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato, I would like to welcome both the speakers, chairs and wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, I would like to hand over this online podium to our first chair, Prof. Jürgen Beck.
Thank you so much. Thank you so much for this wonderful introduction, and thank you so much for having us. It's a great honor for me and for Katharina Wolf to be part of this wonderful ACNS education program. My name is Jürgen Beck. I'm heading the CSF section of the European Association of Neurological Societies and chairman of the Department of Neurosurgery in Freiburg in Germany. And one of our focus areas in Freiburg is indeed spontaneous intracranial hypotension. We treat a lot of patients with this disorder, and we have specialized on treating patients with spinal leaks. So Katharina Wolf, he is attending in my department, also a neurologist, and she specialized in headache, in CSF and spinal cord motion, and has a lot of experience in diagnosing and also treating these patients. So probably I can share the first slides and give you just the first 5 slides overview before I hand over to Katharina Wolf. The topic of the talk is spontaneous intracranial hypotension. And to give you a framework where we are very happy that we are invited by the Asian Society. We are based in Europe, in Germany, and in the southern part of Germany, where you can see the star. And right now, at this very moment, I have to apologize. I'm in Switzerland in in the high mountains, as you can see, in 2,500 meters height, and I have no opportunity to join you inside, so I have to be outside. So, but no problem. A short introduction to Freiburg and Breisgau, which is a small city in Germany, only 250,000 inhabitants, beautiful, very cozy city. But despite it's very, very small, we have a huge university, one of the largest universities in Germany and the largest neurosurgical university center in Germany, as you can see here. And the next slide, please. Yeah, and the next slide. And despite being a typical neurosurgical center, we have one additional focus area since like 2 decades already, where we're focusing on CSF disorders and especially on spinal CSF leaks. So we have, we do not consider SIH, spontaneous intracranial hypotension, as a rare disease anymore. It has the same prevalence as subarachnoid hemorrhage, and we do indeed treat 500 patients a year only with this disease, have almost 400 surgeries for spinal leaks, do several hundred blood patches a year, and have several research areas. But with this, again, thank you so much for this great opportunity. I would like to introduce my huge team. First of all, of course, Katharina Wolf and many others, Florian Volz, Horst Ullbach, Niklas Lützen, and even ophthalmology and anesthesiology who are joining us to further this disease. With this said, thank you so much again. And now I hand over to Katharina Wolf to give you an overview of a diagnosis and treatment of spontaneous intracranial hypotension and spinal CSF leaks. Thank you so much.
Well, thank you for this introduction and having the opportunity to speak across the entire world now to this audience. And it's one of the topics it's not only our hobby, it's what we do every day and what our heart goes. And I hope you can come with me, and I would like to talk about dilemmas in SIH diagnosis. Those are my potential conflicts of interest, nothing much to worry about. And in my talk, I would like to give you a short introduction. Again, what is spontaneous intracranial hypotension? What do we talk about? And why is it important to care about this disease? Is it relevant to you? The main part of my talk will be about the dilemmas in SIH diagnosis. So what is the challenge once you see the patient for the first time? What are the challenges of the basic SIH diagnostics, and what are the major challenges finding the leak? Spontaneous intracranial hypotension is caused by a spinal CSF leak. We divide them in 3 major types. You do see ventral leaks, that's the most common type. Usually it's caused by a ventral bony spur at the site of the mainly thoracic spine. The most of the levels are between the lower cervical spine and the upper lumbar spine. Any other level is suspicious to be wrong. The ventral leak is about 50% of all the leaks. If you have localized the leak, you most often find a bony spur, but the bony spur does never indicate you the exact site of a leak. Then we do have lateral leaks. And lateral leaks are again a dural tear at the side of the dura mater, again at the spine, usually at a thoracic level, and they are most commonly below the lateral nerves, the radices, and there are some very related in the lateral area where the nerve roots leave the dura. And then there is a very quite new type that we find more often. It has been there before, but we have not been able to depict it. It's a CSF venous fistula. In this case, a vein is connected to the CSF space and drains the CSF space. And that's not that easy to diagnose and to treat, but it seems to be more prevalent than we formerly thought. There are less typical or less common found leaks. On one hand, there are sacral dural tears that can cause SIH that has been described by Nicholas Litzen, and very rarely there's also a primary CSF lymphatic fistula. Those have been described in mainly syndromatic patients, mainly children with syndromes, but the CSF can also directly drain into the lymphatic system, which has also been recently described by Nicholas Litzen from the Freiburg team. What happens? The CSF is drained at the level of the spine and causes a hypovolemia inside the head. We see some form of brain sagging, engorgement of the veins, meningeal enhancement, and subdural fluid can be seen. And all of that causes several symptoms, mainly orthostatic headache. Most of our patients present with a new orthostatic headache, a headache dispersions once they sit up, stand up, and that is tremendously relieved once they lay down. You have already heard what the incidence is. You all know about subarachnoid hemorrhage. The incidence lies about 5 per 100,000 per year, higher in the Japan area, but that's about the incidence all over the world. And so you probably see in a center one every week. Do you see that many SIH? SIH does have the same incidence per year, but we don't see them that often. It's probably because we are not sensitive enough. But again, it's important to know better about this disease. It's a disease that mainly occurs in the female population and mainly in the working population. The main age is between the 30s and the 50s. And if we look at our own cohort, so about almost 300 patients, we see we do have a female population in our SIH cohort. We see mainly ventral leaks, but we see more and more CSF venous fistulas. And that's also a little bit curious because CSF venous fistula patients are older than the other ones. So probably we are yet missing an important part of the patient cohort. Again, all of the patients are between mainly their 30s and their 50s. So they are all from the working population. And that's important, not only for the patient's wealth and social security, but also for our social systems. In China, we should expect more than 50,000 cases per year. In India, same. So we should probably see more, and we can do a difference. If we find a leak and close the leak, the patient gets better. Most of our patients regain their complete health. From our own data, we saw that if we just look at headache impact, they come from a very severe headache impact to almost normal headache impact after 6 months or even no headaches. If we look into quality of life, this is a European measurement of quality of life. The average in Germany is slightly above 80. Before that, they are as bad as patients before cancer treatment. And after targeted therapy, surgical therapy of the spinal leak, they improve tremendously. And it's not just us finding those numbers. Other groups looking into targeted therapies that aim to seal the leak, they find similar values. Up to 90% have a substantial improvement and about 60% regain complete health. And that's also important, again, for their working capability. Before treatment, this is a smaller number from our cohort, none of them was able to work. And after surgical closure of the leak, 80% regained full work capacity. And at this point, I would like to cite a very good friend and colleague from London, Leilani Carlton-Jones. She ended her talk in Nagoya, Japan last year in a session on SIH. Is your team finding enough leaks? And most of the teams are not. So I think to get now into my main part of the talk, what is the biggest dilemma in SIH diagnosis is awareness. And of course, we need to talk also about resources. Later on, we will talk about a lot of high-resolution imaging, advanced imaging, and probably not all over the world we can offer such detailed imaging, but we should aim for one center per country at least to tackle this disease. Now, about the outpatient challenge. There are many reports on the many various symptoms of SIH. Again, 85 to 90% of the patients present with a new orthostatic headache. Most of our patients can tell us the date when their headache began. So that's if you hear something like that, you need to think SIH. On the other hand, there are about 15% without orthostatic headache or the sudden begin, so it's more difficult to pick up on them. We have a high inter-individual variability, and it's important to know that over time, the symptoms can change. So over time, the patient might not complain about an orthostatic headache anymore, but might rather complain about vestibular symptoms or cognitive impairment. Another patient might complain about chronic headache, might not even have any orthostatic feature in their complaints anymore, and maybe some paresthesias coming and going. So what you need to do is going back and ask about beginning. That's why one of the most common misdiagnoses is migraine. If you look into the different components how SIH can present, you have a headache, a female person who's coming in their 30s, telling about visual disturbances and noise sensitivity and some nausea and a headache, needing to lay down. Migraine would be the most likely diagnosis to be given by a GP. But the headache might not be orthostatic, then it's even more difficult to pick up. So migraine, new daily persistent headache is a differential diagnosis that does not exclude SIH. You need to, again, look at the entire picture. Cervicogenic headache could be a differential diagnosis or misdiagnosis, same as post-concussion syndrome. Many patients, or not like a proportion of the patients, tell us about the trauma before SIH. So post-concussion syndrome with the many various symptoms is very much alike as the accompanying symptoms in SIH. So this might be another misdiagnosis. Now, on the real differential diagnosis of orthostatic headache, and here it is very difficult. The hypermobility spectrum diseases like Ehlers-Danlos and so on, they have an overlap to postural tachycardia syndrome, and both of those cohorts can present with orthostatic headache. Yet they do not exclude SIH. Professor Beck at his time back in Bern and his group, they did research on POTS patients and SIH patients. 27% of POTS patients presented with orthostatic headache. And all of the SIH patients who have been investigated fulfilled criteria for POTS. So POTS does not exclude SIH. And there's another differential diagnosis, persistent postural perceptual dizziness. Dizziness syndrome that comes once the patient sits up and stands and can present with orthostatic headache as well. Those reports have not looked into SIH as one of the possible underlying diagnoses, so there might be an overlap here as well. We need to talk about intracranial hypertension as well for two reasons. On one hand, we can see paradoxical orthostatic headaches in hypertension, intracranial hypertension. That might be explained by a very curious finding that after getting up, the ICP amplitudes, they can rise in hypertension, intracranial hypertension, and can be possibly part of this orthostatic feature in intracranial hypertension. You can see this image here in the middle where the ICP and the amplitude rises after standing up. On the other hand, we now need to talk again about intracranial pressure. SIH is not a disease of low pressure, it's a low volume disease. And especially over the course of the disease, if you measure the opening pressure on a lumbar tap test, more than 2/3 of the patients have a normal pressure, some even elevated pressure. So we do not recommend to perform a lumbar tap test in SRH. It will not help you to discern the diagnosis. If it's low, okay, but in most of the patients, it will not exclude it and you will not get any further in the process. On the differential diagnosis, now getting in the more rare area, patients present with a lot of vestibular symptoms and even vertigo and even paroxysmal vertigo. There has been a description of a patient presenting as Meniere's disease, and we've seen like very few of them as well, with less headache but more vertigo. In my experience, you can discern them by the feature that they can actually disrupt the attack by laying down. Also, a very common misdiagnosis is something from the psychiatric disorders, psychosomatic disorders, mainly depression. Patients present with concentration difficulties, nausea, gastrointestinal symptoms that are very commonly connected with psychosomatic disorders, noise sensitivities, like the sensitivities to outer inputs. And most of our patients tell us that they have been given a psychosomatic disorders and they have been asked to see a psychiatrist. And that's one of the major misdiagnoses that has also been already reported by Walter Schieving in his report in 2011. Cognition and SIH is also differential or an overlap we need to discuss. There is this disease of brain sagging dementia that can present as a frontotemporal dementia type. So if you have a young patient, especially young onset dementia, you need to look at the brain, and if you see brain sagging, some proportion of those have underlying spinal disease, spinal CSF leak. And you can treat that, and you can treat and resolve the dementia by that. On the other hand, we find in our normal SIH cohort, like patients around their 40s, 30% present with mild cognitive impairment, not brain sagging patients, but normal SIH patients. So we think that there is overlap or not yet understood connection between brain function, cognitive function, and impaired CSF circulation. A very curious, very rare differential diagnosis is a bibrachial amyotrophy, where you can see atrophy of the muscles, and you can mistake this as an ALS. On the other hand, if you have a patient suspicious for ALS, look at the spine. That's a treatable disease. Of course, iatrogenic CSF leaks are a major differential diagnosis. It can happen after lumbar tap test, so a classical postural puncture headache after peridural anesthesia, spinal anesthesia, and infiltrations. And the performing physician might not even have noticed that they have punctured the door, so it's important to ask about that. And in most cases, an iatrogenic CSF leak is an iatrogenic CSF leak. We just have to keep in mind, and that has been recently reported by Walter Schieving as well, that SRH can worsen after dural puncture. So we again need to ask about the beginning of symptoms. After having talked about all this differential and how you can take a wrong turn seeing an outpatient, again, 85 to 90% do have a new orthostatic headache. So you need to ask for the beginning of the symptoms. Now let's step forward and look into diagnostics, basic SIH diagnostics. You need to perform, or what we perform is MRI head, high resolution T1 with contrast, and a high resolution MRI of the spine. On the spine, you need to take care that you have a water sensitive sequence. We do heavily rated T2 fat set MRI, but also some perform CIS or similar. You just need to look for the water that's outside of the door to see the water express CSF egress in the imaging. Let's now look at the brain imaging. If you see an image like that, that's SRH. It's not a meningitis. If the patient is awake and doesn't have a fever or any infect, it's SRH. It's not Chiari. That's completely SRH. You see the meningeal enhancement. You see the engorgement of the venous, of the veins. You see the severe brain sagging here. Those signs have been gathered by Professor Beck and the group when he has been in Bern. And it's now called the Bern score. That has not been done by the group. It has evolved over time, that this SIH score is now called Bern score. And you actually measure several distances. You measure the suprasellar cistern, the mammilopontine distance and the prepontine distance. And again, you look for the engorgement of the veins, the subdural collections, and the meningeal enhancement. Those come up to a certain scale, and then you can indicate the likelihood of a spinal CSF leak. So a Bern score coming from 3 to 4 has an intermediate likelihood of an underlying spinal CSF leak, and 5 and higher is a high likelihood. I would like to show you some more images to demonstrate that you actually need to measure. Here you see the image I showed you before, full-blown SIH. You don't need to think about it here. You already see, okay, there's meningeal enhancement, engorgement of the veins, and the distances are decreased, but not as the brain sagging is not as severe. So you actually need to measure. This is a full-blown image of a SIH. This is as well, and now I did not put on the errors, that you can actually see the distances. You need to measure them. They are decreased, and the patient has engorged veins. I apologize, it's maybe not the best picture, but this is the Bern score 6. So high likelihood of SRH. And now we come to a dilemma. Over time, those signs can resolve. So a Bern score of 0 does not exclude SRH. This is you could even talk about whether this is beginning empty cellar, so maybe rather hypertension, but this is a patient with a ventral dural tear. That's why you need to look for the spine as well. A few other features. If you see especially bilateral subdural hematoma, you need to think SRH. There has been several reports of retrospective nature with incidences even up to 80% of spinal CSF leak as an underlying cause of subdural hematoma. That's too much, but probably we do not yet see enough or do not investigate enough for spinal CSF leaks in subdural hematomas that we have not yet understood if we are true about it. And there is another very important feature, that's superficial siderosis. And if you see infratentorial superficial siderosis, you need to think SRH. You need to investigate for the spinal leak, not just to try and treat the superficial siderosis, but to hinder further progress. Amir El-Rahal, a colleague from our team, he has looked into the patient subset with superficial siderosis, and interestingly enough, some of the patients improved. The symptoms that were related to superficial siderosis were better after finding and closure of the leak. So that's not enough yet to promise improvement, but it's a first sign. Now, let's look at the spine. We talk about this term SLAC, spinal longitudinal extradural collections. That means the collection of extradural fluid, which you can see here in the images. This is an image with very extensive SLAC, but sometimes SLAC can be very confined even over the time of the disease. That's why you need to investigate the entire spine. Do you know now where the leak is? You might find a bony spur. No, it doesn't matter where the main extent of the SLAC is. It does not tell you where exactly the leak is. You just know that there is a leak if you find SLAC, but you do not know where it is, and it's absolutely not recommended to do any explorative surgery or any trying to do targeted treatment at this point. You do not know where it is. At this point, you should perform just an epidural blood patch. Also, some words on false localizing sign. it has been described by Dr. Schieving in 2004. Here it's a CT scan, but you also can see it on a water sensitive MRIs. It's a water collection at a level between the level C1 and C2. And that's a very common finding in SLAC positive leak types, and it does not indicate the site of a leak. You need to actually investigate it, and there's no point of exploring at that level or treating that level. Let's go now further and look into how we can find and actually seal the leak. When should we do this? Because probably not everyone can be referred to center. It should be done after a blood patch did not help or the blood patch did not seal the leak. It should be directly done if a patient already presents with neurological deterioration and sequelae of SRH that you can find on the clinical examination or the imaging, meaning superficial siderosis, especially in this context. And that again means, on a side note, you always need to do follow-up, clinical and imaging follow-up. And how do you find a leak? You need an interdisciplinary team. You need to team up with the neuroradiologist and the clinicians, the neurosurgeons, to find a leak and to treat it. We now have to come back now to the leak types. Lateral leaks and ventral leaks are typically SLAC positive, so they have extradural fluid that you can see in the MRI screening. CSF venous fistula is SLAC negative. There's no egress of CSF outside of the dura, so that's harder to pick up on the spine MRI, or actually not possible to pick up on the spine MRI. So you need to divide your patients into SLAC positive, SLAC negative for the next steps. This is an overcrowded image of our SOP, of our standards, and I would like to point out a couple of steps we usually follow. So if we find SLAC, epidural fluid, the highest likelihood, 50%, is that we see a ventral leak. So the patient needs to lay on his belly. You need to have a neuroradiologist who has seen a couple of those investigations. That's not a typical CT myelogram or digital subtraction myelogram that you need now to find a leak. It's a dynamic imaging. You need to pinpoint the exact site of the leak. And for that, you need to position the patient in the right order. For ventral leaks, the patient needs to lay on its belly and the head needs to be tilted down a little bit. And then usually our neuroradiologist performs a digital subtraction myelogram, which you can see here. And now there is the image coming, and here you just see the breach, the egress of the leak, exactly here. And that's the spot and the timing that's so important to see this little part of the leak. And now you have localized it. Now you can start thinking about how to treat that. With lateral leaks, it's about the same. By now we have some means where the neuroradiologist decides to start with a lateral precision, but most of the time it's starting in prone position and then going to lateral position after that. If the first one was negative, investigating for the lateral leak. And the lateral leak looks like this in the digital subtraction myelogram, and this is a specialty of Nicholas Litzen, again, a cone beam CT to investigate the details of the lateral leaks, where you can then exactly see where the egress is and plan surgical treatment far better. And I have another image of a lateral leak here where you can see where it starts to egress at this point and then fills up in the extradural space later on over time, and again a cone beam of the same lateral leak. If we do not have SLAC, you need directly go into the lateral decubitus position, head down, And then you need to perform some type again of a dynamic myelogram. You can do CT myelogram dynamically or DSM again, and then you can find a CSF venous fistula that when first they began here haven't been that nice as described as you can see in these images, but they are now piece of art once Nicholas finds them. And you need to see the vein. You need to actually see the vein that drains the CSF. Most common pitfall is that some see and treat just the nerve root sleeve or something like that. You need to find and be able to follow on the vein that egresses from the CSF. Now, again, why is it important to take the time to have a neuroradiologist that knows how to perform dynamic myelogram? Blood patching is still the easiest way and the most feasible way to treat CSF leaks. You do untargeted lumbar high volume blood patch, and most of the patients, they have a relief after that. They get better. There is even some data on long time improvement, while improvement is defined as a 30% improvement of their general symptoms in 30 to 50%. So they get better, and sometimes they even get better for a longer time. But Eike Pischowiak from the Burn Group has looked into the data, and even the ones that got better, they still did have leaks. 70% have not been sealed, and they are still at stake to develop sequelae of SIH. So you need to follow up on blood patches, and if they're not better, you need to find a leak. And even if they're better but still imaging is positive, you need to go over into targeted therapies, because more than 60% have complete resolution, can go back to their lives, can go back to their work. And 90% have substantial improvement, meaning more than 50%. So this is why it's so important to get those people back to their lives. For surgery, we can report from our own data that we have 3 to 4% revision rate, so 97, 96% succession rate in sealing the leak. So we have 70% failure after blood patches and 3 to 4 that need revision surgery after targeted therapy in our center. A little bit about how to seal the leak. I think that's has not been the major part of the talk, but I would like to go over that. You can do targeted patching in lateral leaks in CSF venous fistula, and there have been reports about good success in that, especially from the teams that focus on this technique, from the King's College, Lani Carlton-Jones and Andrew Cullen from Denver, and they report success rates of 70–80%. You can perform transvenous embolization in CSF venous fistula. That's a technique where you come from the epidural veins and try to target the draining vein by onyx embolization. The group from Walid Princiki, they reported good success rates in 100 CSF venous fistulas treatments, and they've been in the same range as targeted patching. Yet in our experience, some of them reopened, so you need to follow up on those patients, especially if they're still symptomatic. And then we have the option of surgical treatment, and here one fits all. You can treat all the leaks by surgical procedures. In our center, they are all minimally invasive with a tubular retractor, only 2 centimeters, with a very tiny bone defect after the fenestration that has been named keyhole fenestration. And even the most distant ventral leak, where you have to do a transdural opening, the success rate is very high, and there is no yet major motoric dysfunction or sensoric dysfunction after this procedure that maybe Professor Beck can later on talk a little bit more if we have the time. this is the cutting of the ligament, and then the exploration of the ventral leak across the myelin, and there is a little movie about this. I hope it works. Sorry, I go back. Okay, where you can see the durotomy as the first step, then how the door is lateralized, and the exploration of the leak. And now you see this, you've just seen the slit on the ventral side of the dural that's now patched. It's called a sandwich patch technique, where you have a tarocele coming from the outside and then tarocele from the inside. And then the dorsal part of the dura is sutured and closed. So now we've talked a little bit of what I'm not familiar as a neurologist, the surgical treatments, but mainly the dilemmas, how to get to the right diagnosis in SIH, which I find, if we stick to the major parts, that asking for the beginning of the symptoms should get us there. And then if we do the right image reading, measuring burn score, we should pick up the main number of SIH patients and should be able to treat them. With this, I would like to finish my talk and tell you a little bit. I talked about you need to have a neuroradiologist who's able and capable to perform the imaging and the myelogram. So I would advertise a little bit about our center. We started to do visitorships. We invite teams. We encourage teams to come, neuroradiologists, clinicians, and see our hands-on day-to-day work. And we always invite specialists from other countries. Our last visitorship was just in October, with Professor Studley from Sydney, Professor Vukic from Zagreb, and our next visitorships are just coming up, and you can stay tuned visiting our homepage that you can see or connect with using the QR code. And also there is a very interesting conference coming up in Amsterdam in June this year that is organized by Sinai, so Wouter Schiving, Duke, with Peter Kranz, and the Amsterdam University and ourselves. And I think that's going to be the who is who and the latest research and how to diagnose and treat SRH all in 2 days, very confined and probably very good time and for meeting and chatting and networking. So that leaves me to thank again for the team. Everything I told you is because I'm part of the team, and I'm glad to be able to be here and work here. And with that, I would like to finish and happy to take your questions.
Thank you very much for this excellent overview and excellent talk. I already can see a question by Dr. Ben G. Can you activate your microphone?
Ben?
Yes, and thank you so much, Carolina, and I think it's a great talk, and I'm deeply interested in this topic because I think that in our daily difficulty is the resistance by the radiologist to get the imaging. Usually I have to lie the patient like for 2 weeks or even a month because they are symptomatic, and then to get maybe ask them to drink coffee to see if it's getting better while waiting for the imaging. So my first question is about like, because the resistance with the radiologist is that they think that the scan, the MRI, I mean, first of all, for the brain part is not sensitive, whereas for the spinal part, they think it's not necessary to know the level, and they are not very confident to interpret whether there is a leak. Because sometimes I encounter cases seeing some diverticulitis around the left shift, left shift region, and I think there's already enough if the clinical suspicious. So, but most often, and they are not reluctant on that. And also with the MR myelogram, And one of the comment is that the use of the gadolinium contrast, the intrathecal use of the gadolinium contrast is not FDA approved. So it's one of the arguments that this scan should not be conducted in a clinical setting. So this is my first question about the imaging and what's your view to it. My second question is about, because I'm a neurosurgeon and I occasionally I do a few cases of a bilateral chronic subdural symptomatic to relieve the mass effect. But if I think that the history is suspicious, and also if I think that is intracranial hypotension without imaging during the operation, before I puncture, I open the DWI to relieve the CSF, I use the needle to insert into the subdural space to measure the pressure. So it comes to me that like the pressure, for example, for bilateral subdural hematoma with mass effect. Interestingly, in some cases of a suspected spontaneous intrahypocranial tension, the pressure is like 0 to 1 for me in some of my cases. So I would like to ask about, would that be, could that be a diagnostic of this condition? Yes, and whether I should proceed to like a the lumbar, the epidural butt patch, if the radiologist reject the scan and I don't have the MRI, should I proceed based on this piece of the information? Yeah, thank you so much. And I have so many questions and hope to learn from you more with it.
These are excellent questions. You are excellent questions right at the heart of the problem. So I might comment this briefly. First, you are completely right that there is a dilemma that the community, neurology community and neuroradiology community is not ready for this disease yet. This is why we are so grateful that you have invited us to talk about this disease. We need to inform our colleagues that SIH does exist, and there are many, many, many patients out there that we leave undiagnosed, and you can make a difference. And 2 steps. First thing is recognize the signs on brain MRI. And the second step, you need to ignite the fire in your colleague neuroradiologist that this disease is also fun. It's a tough disease. You can follow the path of diagnosing. You can do detective work, and it's so rewarding once you find the leak and you can cure a patient. It's amazing. So there is a certain hurdle, but once you're over this hurdle, it's a fun disease and you can help so many patients. And Katharina can comment on the diagnosis in a second. The second part of your question is excellent as well. And there's a really high tendency for especially young patients with bilateral chronic cerebral hematomas. They do have leaks. If you have a patient younger than 60 years of age, 60 years old, younger than 60 years old with bilateral subdurals, I think the chance of finding a spinal CSF leak is 30, 40, even 50%. So follow up these patients with spinal imaging and a search for the leak. And the second advice is do measure the pressure, as you do, excellent. And the third advice is keep these patients, contrary to all the other neurosurgical patients, with their head flat and bed. Do not elevate the head and bed, because CSF continues to drain. You can even do these patients, you can make them worse. So excellent comments. And I would give Katharina Wolf the opportunity to comment more on the diagnostic part. Thanks for these questions.
Well, thank you. I think that was you just put your thumb on many questions we are thinking about too. Okay, and maybe just one comment again on the imaging. You were saying gadolinium, intrathecal gadolinium is off-label, of course. You wouldn't need that for the myelogram. You just need water-sensitive sequences without gadolinium, so you don't need to apply that. And in Germany, we have the same problem with the outpatient clinics, radiologists as well. They just do one imaging per quarter, and they refuse to do more than cervical spinal image and so on. We get now step by step our radiologists to perform entire spine within less than 12 minutes. If but they need to be ignited. They need to get the fire across, and maybe they get more interested once they see that they can actually also heal and seal the leak and get involved and with the high shots as Shiggy and so on. And about the diagnostics, I think exactly with the chronic subdural hematoma, you were absolutely on the right task, and this is the best thinking you have. And we sometimes worry about is it okay to reduce the mass effect, but it is. From what we see, and it's probably important to do that as soon as they have a mass effect. You could also argue that you do another hole up here, and they have already one down there, and they might herniate, but it's okay, but you again need to have them laid down. Maybe you could repeat your idea on the diagnostic. I think I understood that you said you do perform lumbar tap test and measure the pressure to have a first idea where they are.
Yeah, I mean, like if I have the to put the question simple, so if I have the subdural pressure, the measurement is hypotensive.
Mm-hmm.
Is that enough to justify me to do a epidural blood pressure right away without MRI? Maybe to put it this way. Yeah.
Yeah. Thank you. I think that's good. I know where you're going, but I think it's probably not that secure to rely on that, because you probably have a negative pressure or a low pressure in this compartment. But I'm curious what you tell us next year.
Yeah. I see. Thank you so much.
We have one
If I
question
might put
from
it the other way around, it is at least very reasonable to think about this disease and then to follow up with more diagnostics. So there is another question by Dr. Suhas Udayakumaran. Please go ahead.
Yeah, so as a pediatric neurosurgeon, I was wondering, what is your experience with children? You know, how frequently do you see it with children? That's my first question. Second is, I noticed one of the signs which you mentioned was empty sella. I was just wondering, how does empty sella get associated with SIH? Our third very short question is, when you see a Chiari on a plain MRI sequence, when do you initiate a contrast sequence?
These are, again, excellent questions. The second question, empty sella, it is not an empty sella sign. It is the distance from the chiasm to the pituitary. Nothing to do with empty sella. So we measure the distance from the chiasm to the pituitary as a measure of the brain sagging. You do have very, very rare cases where you have pre-existing intracranial hypertension with an empty sella, but it's a very, very, very rare case. What we meant to show you is that you have to measure the extent of brain sagging. And one of this measure of the extent of brain sagging is the distance from the chiasm to the pituitary. Okay, this is the first. The third question with the differential diagnosis to Chiari is extremely important. As a referral center for SIH, we see many, many patients operated on for Chiari that actually did not have a Chiari malformation. So the low tonsil sign is not enough to discriminate Chiari from non-Chiari. So you need to look at the whole brain that is sagging down, that is, you have a flat pons, you have the distance from the chiasm to the pituitary, and then you can discriminate SIH mimicking Chiari from the real Chiari. And you can prevent a lot of kids getting surgery that is unnecessary and even harmful for them. And the first question I forgot.
The prevalence in children, because I don't see, I'm not seen a child with SIH.
Very low, very low. It's a disease of the 30 to 50-year-old patients, not of kids. We have 1 or 2 kids, but out of 1,000 patients or so, it's rare.
They may be iatrogenic more than spontaneous.
Exactly, you're right.
Yeah. Thank you. Great talk.
Thank you so very much. So I have a few questions, be a rapid fire like things, because there are too many. First thing is, what is the natural course of this disease? Is there a spontaneous remission?
It's very different. We know few cases with spontaneous remission. In those cases, there is no data on that. What's the natural course going ahead? We know that we expect that 15% develops superficial siderosis in SLAC positive SRH.
Okay.
We see deafening in the long time of the course of the disease. So those are, and of course cognitive impairment. That's why we follow up. Even if they're completely healthy, if they still do have a leak, they're at risk to have long-term sequelae of SIH. The exact numbers are not yet known, to be honest. And then we have a huge bias. I think we are a center, tertiary referral center. We see those who are not healthy. So probably we are the wrong persons to be asked. In our experience and our impression, no one gets really healthy. They get better. All of them get better. And they cope, they lay down, they try and go back to work, and they lay under the desk after 3 weeks. And probably depending on the culture, we did have Asian patient, and he worked the entire day. He got back to work, but he needed to lay down repeatedly and somehow managed to get his job around that. And he wasn't able to live his life other than working, no social life.
Thank you.
Excellent answer.
Okay. Yes, Prof.
I might only add, to put in very simple words, if patient gets better with a blood patch, this is not enough. You need to restitute ad integrum, so they need to get completely healthy. Only then you need to stop. Otherwise, follow the patient, look for the leak.
Thank you. The second most important question is, what is the mechanism of healing after epidural blood patch? I don't believe that the blood will go and seal the leak, because having myself done thousands of surgeries for spine, I don't think that it goes and seals the leak. And the second is, what is the high volume blood patch? And do you give plain blood or do you mix it with fibrin glue?
I can answer the first question and Katharina the second. So I completely agree with you. After several hundreds of leak surgeries, I personally did, and all these patients got a blood patch beforehand, and I never saw a clot plugging the leak. So this is fantasy. There is somehow a mechanism, because they all get better, a little bit better, that there is a change in pressure from the epidural to the intracecal space, and there's a shift of CSF from the lumbar to the cranial compartment, and they get some relief. And there's a change in the venous drainage pattern, but there is no cure usually. This might happen with a fibrin glue, but not with a simple blood patch. And I hand over to Katharina for epidural blood patching and the volume and fibrin glue.
So to make it short, high volume blood patch is 20 milliliters and more, although the aim is that the patient feels some pressure. So it's not just the volume, but that the patient feels some pressure in the lumbar space, and usually that's the part. And when you feel more resistance, that's the part to stop. Here in our center, we do it under guidance, under imaging guidance. So the neuroradiologists do it because our patients are very sensitive, of course. And they usually just do it with a small pitch of dye, so they can see they're in the epidural space, but not in a mixture with fibrin glue. It's rather the volume, not the glue. So we don't, as you said, we don't expect anything to actually patch the hole, but to lower the compliance, to put more pressure into it. So it's just the normal blood.
Thank you. We can take one last question from Dilshod Mohammad Aliyev. Yes, Dilshod.
Thank you so much, dear Dr. Katharina. I have a question. Is there any clinical discerning sign of this SIH from Chiari malformation, classical clinical signs, like if the patient came up with this MRI with descending tonsils and the classical clinical signs of Chiari malformation, and there is a suspicion for the SIH, how we can differentiate from the clinical signs? Is there any nuances?
to I see the shaking head already. There is not like one sign you can say that's specific and sensitive, because they're probably both are CSF circulation disorders. And to be honest, we have not understood what Chiari is at the same time. But we see rarely coughing headache in SIH, but you cannot discern it by that. So that's something that's not a typical in SIH. You find rather in Chiari, but same symptoms, so gait disorders, and can just be in SIH. I think there is, on a clinical basis, if you have the new orthostatic headache with a sudden begin, you're rather on the SIH side, but the imaging will tell you. You can discern Chiari from SIH if you need to look into those images a couple of times, and then you see how the pons looks different and how the angle of the angles are different.
Right.
Okay, then mostly it's neuroradiological signs.
Yeah.
Well, thank you, Dilshod, and we are extremely grateful to both Professor Judging Beck and Prof. Katrina Wolf for this exciting lecture at the ACNS webinars. We had a fantastic start for 2025. Any closing remarks from our Honorable Chair?
Thank you so much for having us. Thank you so much for inviting us. And you are all always invited to come to Freiburg to take part in our biannual or 2 times a year CSF courses. They are free of charge or very, very minor charges. We do love this disease. We do love to teach, to show you. You are always invited to come to the operating theater to see how we do the surgery. You are invited to come to the radio suite to see how we diagnose it. So we have fun treating these patients, and it would be a pleasure to have you in Freiburg. And thank you so much. And thank you, Katharina, for the excellent talk.
Thank you.
Thank you very much. So I think now it's time. We'll move on to the second session. I'll hand over this podium to our Honorable Chair, Dr. Suhas, who will say a short introduction and invite Dr. Singhua for his lecture.
Thank you, Dr. Raja, and thank you, ACNS. So the next talk is a very key talk when it comes to pediatric neurosurgical, neuro-oncological topics. And every fourth or fifth tumor which we come across is a posterior fossa tumor in pediatrics. And any time we come across a posterior fossa tumor, the first concern is what is the tumor biology, what is the grade, and probably how to counsel the family and how to prognosticate at the beginning itself. And of course, any pediatric neurosurgeon or any surgeon who is related to treating children would first like to avoid mutilation when it comes to children. So understanding the biology is key to further discussion beyond the first diagnosis on a radiology. So DWI is coming up as a very key element of a diagnosis beforehand, before the surgery, on what could be the tumor biology. Of course, seconded by radiogenomics, which is upcoming. So Professor Ding would talk on DWI as an element of tumor biology understanding on posterior fossa tumors in children. So Dr. Ding, Professor Ding, please go ahead with your talk on DWI in posterior fossa tumors.
It's my pleasure to attend in this meeting, invited by Professor Xu Bing. And I'm Dr. Ding Xinhua, come from Neurosurgery Department of Huashan Hospital, affiliated to Fudan University, Shanghai, China. The topic of my speech is research on differential diagnosis of common tumors in the posterior cranial fossa of children based on diffusion-weighted imaging. As we all know, children are not a smaller version of adults. So our research should answer 3 questions. 1. What are common tumors in the posterior cranial fossa in children? 2. Is it difficult? 3. How to improve the accuracy diagnosis before operation? Before starting my speech, I'd like to show 4 cases of a tumor. And you think it's challenging to do the accuracy diagnosis before operation? And I will announce the answer at the end of my speech. So first, I give the definition. Posterior fossa tumor in children refer to tumors located below the territoria and above the foramen magnum in individuals less than 14 years old. There were many types in this area, including medulloblastoma, pilocyte astrocytoma, diffuse midline glioma, epidemoma, choroid plex papilloma, cavernous hemangioma, ganglion glioma, pediatric low-grade glioma, cholesteatoma, even sarcoma, hamartoma, metastasis tumor, hemangioblastoma, and more than a dozen other types. According to the literature, 45% to 60% of the pediatric brain tumors occur in the posterior fossa region, with higher surgical complications. So, different tumors have different treatment methods and outcomes. Accurate preoperative diagnosis is very necessary. So my research purpose is to explore methods to improve diagnostic accuracy. The method is first, we retrospectively analysis of all pediatric posterior fossa tumor patients who underwent surgical resection from January 2021 to January 2024 in our medical group. The clinical case data and the radiological diagnostic reports were analyzed, dividing the posterior fossa tumor into 4 areas: brainstem, false ventricular, cerebellar pointing angle, and the cerebellum. The incidence, characteristic, and the radiologic feature of the top 3 tumors in these areas were analyzed, and a diagnostic flowchart was proposed based on the literature. And our including criteria is 1, initial tumors located in the posterior fossa. 2, age less than 14 years old. 3, all underwent surgical resection with postoperative pathological diagnosis of tumor. And our explosion criteria is 1, recurrence of tumor or second surgery. 2, patients with incomplete clinical data. So, localization diagnosis, tumor originated from the cerebellum morbis, growing into the false ventricular, or primarily occupy the false ventricular space, are diagnosed as false ventricular tumor. 2, tumors originated from the brainstem or with the main body in the brainstem are diagnosed as brainstem tumors. Tumors originating from lateral aperture of the false ventricular, growing to the CP angle or with the main body in the CP angle are diagnosed as CP angle tumors. Tumors originating from one cerebellar hemisphere or with the main body in the cerebellar hemisphere are diagnosed as cerebellar tumors. The accuracy of the preoperative localization diagnosis is determined by comparing surgical records with preoperative imaging diagnostic reports. And the next accuracy diagnosis is qualitative diagnosis, based on preoperative CT and MR qualitative diagnosis. If the preoperative image diagnosis matches the postoperative pathology diagnosis, it is considered accurate. If not, it is considered incorrect. A diagnostic of a space-occupying lesion in a certain area or a vague diagnosis of glioma without distinguishing between high-grade and low-grade glioma is considered vague. Result is a total of 118 eligible patients were included in my study, aged from 2 to 14 years old, with an average of 8 years old, 7 males and 48 females, with a rate of 1.46 rate 1. 41 cases of false ventricular tumors, 38 cases of brainstem tumors, 30 cases of cerebellar tumors, and 9 cases of CP angle tumors. 13 cases were incidentally found during the physical examination after cranial trauma, with no clinical symptoms. The remaining 105 children's common initial symptoms were headache, vomiting, dizziness, unsteady gait, and strabismus. Truly, localization meaningful symptoms were rare, with only 3 cases of facial paralysis, 2 cases of swallowing difficulties, and 1 case of facial numbness. The course of this disease ranged from 1 week to 24 months, with an average of 2 months. Okay, false ventricular tumor, the top 3 tumor is medullary-blastoma, 27 cases, pilocyte astrocytoma, 7 cases, epithelioma, 5 cases. The top 3 tumor in brainstem were diffuse midline glioma with H3K27 alpha, pilocyte astrocytomas, and cavernous hemangioma. The top 3 tumors in cerebellar are pilocyte astrocytoma, medullary-blastoma, and cavernous hemangioma. The top 3 tumors in CP angle are pilocyte astrocytoma, cholesteatoma, and medullary-blastoma. Accuracy rate preoperative CT localization diagnosis was 93.22%, with 3 cases of cerebellar hemisphere tumors misjudged as false ventricular tumors, 3 cases of cerebellar hemisphere tumors misjudged as brainstem tumors, and 2 cases of cerebellar hemisphere tumors misjudged as CP angle tumors. Except for cholesteatoma, which appears hyperdense on head CT, all other tumors are mixed higher or low density without qualitative characteristics. 17 cases of tumors had calcification, including 9 cases of medulloblastoma, 5 cases of pilocyte astrocytoma, 2 cases of epithelioma, 1 case of RGNT. Table 1 is chi-square analysis of tumor calcification and tumor nature. The statistical analysis result showed that calcification cannot be used as a basis to distinguish between medullary blastoma, epithelioma, pilocyte astrocytoma, because the p-value is beyond 0.005. Accuracy rate of the preoperative MI localization diagnosis was 100%. 74 cases had accurate qualitative diagnosis. 23 cases had vague diagnosis, and 21 cases had incorrect diagnosis, including confusion among medullary blastoma, pilocyte astrocytoma, and epithelioma, with 18 cases, and 1 case ATRT misjudged as medulloblastoma, 1 case hematoma misjudged as pilocyte astrocytoma, and 1 case choroid plexural papilloma misjudged as epithelioma. Preoperative differential diagnosis of pediatric posterior fossa tumor focuses on medullary blastoma, pilocyte astrocytoma, epithelioma, and diffuse midline glioma. The MI manifestation of common posterior fossa tumor in children is medulloblastoma DWI showed rheocytic diffusion, and contrast scanning shows obviously heterogeneous enhancement with no significant enhancement in cystic area. The epithelioma DWI also showed restricted diffusion, and the contrast scan showed heterogeneous enhancement. Because medullary blastoma originated from the mummies of the cerebellum, while epitheloma originated from the bottom of the fourth ventricle. On extra T2 WI, if cerebellar spinal fluid surrounded the tumor anteriorly, the tumor was considered medullary blastoma. If cerebellar spinal fluid signal surrounded the tumor posteriorly, considered epitheloma. In the pilocyte astrocytoma, DWI shows no rheocytic diffusion. And contrast scan showed heterogeneous enhancement. In the solid part, and no enhancement of the cystic wall. Pilocyte astrocytoma, diffuse midline glioma with H3 case 22 alto. The tumor is usually located in the pons or medullary, shows a frequent encasement of basal artery. Partially area DWI showed rheocytic diffusion, and the contrast scan showed heterogeneous patched enhancement. Table 2. Comparison of the incidence of DWI restriction diffusion, cystic changes in common posterior fossa tumors outside the brainstem in children. So the statistical analysis results show that whether DWI diffusion restriction can be used as basis to distinguish between medullary blastoma, epitheloma, and pilocyte astrocytoma. But cystic changes cannot be used as a basis to distinguish between medulloblastoma, epitheloma, and pilocyte astrocytoma. Table 3 is comparison of DWI restricted diffusion, cause of disease, cystic changes, and enhancement incidence in common brainstem tumor in children. From the statistical analysis, I can show that whether DWI diffusion restricted can be used as a basis to distinguish between diffuse midline glioma and pilocyte astrocytoma. But the cause of disease, cystic changes, enhancement cannot be used as a basis to distinguish between diffuse midline glioma and pilocyte astrocytoma. So, the initial symptom, the size of tumor in this group are generally large. Only 14 cases, less than 12%, have a maximum diameter less than 3 centimeters. When most tumors are discovered, their larger volume means that earlier diagnosis is difficult. For children cannot accurately describe their symptom, especially young patients. Even if hydrocephalus and high intracranial pressure are severe, the child does not complain of severe headache. So if a child repeat complain headache, vomiting, or dizziness, even if the symptoms are not severe, take the child for a CT scan. If a suspicious lesion is found, immediately perform a head MR scan with contrast to confirm whether the lesion is a tumor. So let's discuss the restricted diffusion. Diffusion weight imaging is a form of MR imaging based upon measuring the random Brown motion of water molecules. In general, tumors with higher cell density or larger cell volume shows the restricted diffusion, with high DWI signal and a low ADC signal. The picture A shows the water molecules in a containing along move randomly. It's a Brown motion. In picture B, highly cellular tissue impedes the movement of water molecule. And in picture C, tissue with larger cells also impedes the movement of water molecules. So the picture B and C means restricted diffusion. Okay, let's review the case 1. The tumor located in right cerebellum and with solid tumor and cystic changed. T1 low signal, T2 high signal, and DWI was high signal, ADC was low signal, and the contrast MI showed enhanced obviously. We can see the immunohistochemical staining showed Ki67 positive tumor were densely distributed. So the tumor cell was restricted diffusion. And a post-operative diagnosis is medulloblastoma. Case 2, tumor is also located in the right cerebellum, but we see the immunohistochemical staining showed the Ki67 positive tumor cells were sparsely distributed, and the DWI and the ADC showed there's no restricted diffusion. So the diagnosis of the tumor is pilocyte astrocytoma. 3, it's a false ventricular tumor. And we can see immunohistochemical stain, the Ki67 positive tumor cells were densely distributed in the tumors. And the DWI showed is high signal, ATC is low signal. It showed the tumor cell was restricted diffusion. But in the false ventricular, restricted diffusion showed epithelioma or medulloblastoma. Then we see the CSF signal. In extra T2 DWI, we see the CSF signal located posterior of the tumor. So the diagnosis is epithelioma, and the post-operation diagnosis confirmed. Case 4 is also false ventricular tumor, and the immunohistochemical staining also showed the Ki67 positive tumor cells were densely distributed inside the tumor. And DWI is high signal, ADC is low signal, showed the tumor cell was restricted diffusion. So it may be medulloblastoma or epithelioma. Then we see the T2 extra signal, the CSF signal located anterior of the tumor. So our diagnosis is medulloblastoma, and the post-operation pathologic diagnosis confirmed. So why is DWI diffusion restricted in brainstem glioma less than medulloblastoma outside the brainstem? In my study, in outside the brainstem, medulla has 100% DWI diffusion restricted, but in the brainstem, only 78% of the tumor have DWI diffusion restricted. So we do the research. In this case, we do the biopsy in 2 points. One is enhancement support, another is non-enhancement support. And the result showed although the tumor cell density of unenhanced MI lesion was lower than that nearby enhancement lesion, but both showed positive H3K27M immunohistochemistry positive, and both could be used for the diagnosis of diffuse midline glioma, regardless whether it is diffusion restrict on DWI. So this picture can explain why not 100% of brainstem tumor was diffusion restricted. So we can see this DIPG T1 low signal, but the signal is mixed. T2 high and low signal mixed. And DWI we can see the enhanced spot was high signal, nearby is low signal, and ADC showed the enhanced spot is low signal, non-enhanced spot is low signal. So extra T2WI showed diffuse swelling of the brainstem surrounding the basilar artery, which is as same important as restricted diffusion to diagnose DIPG2 diffuse midline glioma with H3K27 alter. Okay, according my study and the literature, and we summarize the diagnostic flow chart for pediatric posterior fossa tumor. When the children suffered headache, vomiting, dizziness, unsteady gait, diploma, facial paralysis, and do the CT for initial screen, MI for confirmation. Then separate the two parts. One is brainstem, another is outside the brainstem. Next step, we see MR scan DWI diffusion restriction. No restriction was considered a pilocyte astrocytoma. And with restricted diffusion, it would be medulloblastoma or epithelioma. Then we see extra T2I. If CSF surrounds the tumor anteriorly, considered medulloblastoma. If CSF surrounded the tumor posteriorly, considered epithelioma. For brainstem, MR scan diffusion restricted, and we see basilar artery encasement sign. So it's diagnosed diffusion midline with H3K27 alter. Without basilar artery encasement, the tumor should be considered a pilocyte astrocytoma. Okay, let's check the flow chart diagnosis. In case 5, the tumor located in the left cerebellum, low density with cystic change, and T1 low signal of the solid tumor, and the T2 high signal of the solid tumor, and enhanced heterogeneously. So in the cerebellar tumor, top 3 was pilocyte astrocytoma, medulloblastoma, or which one should we consider this type of tumor? And the operative imaging diagnosis reports epithelioma. So let's check the DWI. The solid of tumor was iso signal, show there is no restricted of the tumor. The postoperative pathologic diagnosis is pilocyte astrocytoma. This is confirmed our flow chart. Okay, let's see case 6. tumor located in the fourth ventricular with isosignal dense, and MRI showed the tumor was cystic change. The solid part of the tumor was isosignal, low in T1, low signal in T2, and can be enhanced. Which type of a tumor? From my research, the top 3 of fourth ventricular tumor was pilocyte astrocytoma, medulloblastoma, epithelioma, and which type of this? See, and the preoperative image diagnostic report is epithelioma. Is it right? See the DWI. The DWI showed the low signal of the tumor solid part. It means no restricted diffusion. As my flow chart of diagnosis, the tumor should be diagnosed pilocyte astrocytoma. And post-operating pathological diagnosis confirmed it's a pilocyte astrocytoma. Case 7, a tumor located fourth ventricular, T1 low signal, T2, the tumor was isosignal with cystic change, and also tumor can be enhanced obviously. So which type of the tumor? Fourth ventricular tumor, top 3 is medulloblastoma, epithelioma, pilocyte astrocytoma. Which type? Let's see the DWI. From DWI is low signal, means the tumor has no restricted diffusion, and it should be pilocyte astrocytoma. In the post-operation pathological diagnosis confirmed the tumor is pilocyte astrocytoma. It's a case 8, tumor located in the fourth ventricular with calcification and hydrocephalus. T1 showed a tumor low signal. In T2, the tumor was high signal and the tumor was slightly enhanced. Which type of a tumor? DWI showed the tumor a high signal. It means restricted diffusion. So it could be epithelioma or medulloblastoma. Let's see the T2 signal. T2 signal, CSF signal located anterior of the tumor. Anterior of the tumor. So from the flow chart, the tumor should be medullary blastoma. And post-operation pathological diagnosis confirmed the tumor is medullary blastoma. So my conclusion is, junior diagnosis of children with posterior cranial fossa tumor remains difficult. Diffusion weight MR imaging is an important basis for differential diagnosis. My study summarized the diagnostic flow of common tumor in the posterior cranial fossa of children based on whether diffuse is restricted, which is expected to improve the accuracy of the preoperative diagnosis. And my study has been published in Chinese Journal Contemporary Neurosurgery, September 2024. So thank you for listening.
Thank you, Dr. Ding. It was a very nice talk from your side, and I think it's as you said, posterior fossa are common tumors, and your flow chart is very practical. And I think I had a question for you. So let's say the diagnosis. If you take the diagnosis of medulloblastoma, I mean, recently we are talking about subtypes of medulloblastoma, isn't it? And I'm sure that most of the a subtype like medulloblastoma of extreme nodularity, which is type SH and WNT lost ones. Now, these do not have a uniformly homogeneous kind of density of cells. So how do you explain? Do you see any difference that's going to appear in DWI in the subtypes? In the subtypes of medulloblastoma family?
You mean the subtype of the medulloblastoma according to the gene check? But
yes.
yeah, from the MRI imaging, I think it's difficult to separate four type of genes: winter, group 3, group 4, and so this is a primary diagnosis of a tumor. It's important to do the treatment conclusion, which type of tumor can be totally removed, which type of tumor should not totally removed. If a tumor is a hemangioblastoma, and we should totally remove it because it's a malignant tumor. If the diagnosis is a pilocytoma, then if there is a difficult to do the operation, we should not to totally remove the tumor. I think it's my researchers rules.
Yeah, thank you, Dr. One more question was, I noticed one pilocytic astrocytoma show. I mean, in your series showed restricted diffusion. How do you explain that fallacy?
Yeah, some hospitals do the number of ADC, but in our hospital, the radiological did not regularly give the number of ADC, just the photo of the ADC low or high signal. I asked the radiological doctor, this is not accurate of the number, and they didn't give me the number regularly. But from the DWI low signal and ADC high signal, we can get a conclusion the tumor has no restricted diffusion. And with a high signal of the DWI and a low signal in ADC, we can get the conclusion that tumor was a restricted diffusion.
Got it. Okay, thank you. Any questions, Dr. Raja, other chairs?
There are none. Maybe you can give your expert comments and we can wind up.
Yeah, I think in general, it's a practical way to handle tumors when you first have a first outlook at when you see the MRI. But as time goes by, when these subtypes appear in medulloblastoma, medulloblastoma is considered a family. So subtyping is going to be more important. And probably as time goes by, the radiogenomics will play a great role. So, of course, the DWI is the first step. And maybe grading of DWI itself might play a great role. That's my feeling, because all tumors are not homogeneously, singularly restricted, isn't it? There might be different extent of restriction. So it's possible that the grading of DWI and radiogenomics are going to be key in further radiology of pediatric neuro-oncological tumors.
Thank you. Thank you very much. We are all looking forward to the progress of science and delineate these tumors through radiological evaluation. So I think it's time we can wind this up now. I will close this officially on behalf of the Education Committee of the ACNS and the President, Prof. Yoko Kato. I would like to thank both the speakers of today, Dr. Katharina Wolf and Dr. Ting-Ching Hua, as well as the chairs, Prof. Cherjin Beck and Prof. Suhas Udaikumaran, for the time and support for the ACNS webinars. Very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel. Special thanks to my co-hosts Dr. Liubun Singh and Dr. Ben and Dr. Huifang for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.